All right.
Welcome. Let me introduce you, Greg. Welcome everyone to this weekly session of Virtual Global Spine Conference. We have the honor today of have Dr. Gregory Schroeder. He serves as associate professor at orthopedic sector at Thomas Jefferson in Philadelphia. He was trained in Rothman Orthopedics, his home right now. So he's a pretty well recognized surgeon and has authored I think over 200 peer-reviewed publications. He's now the chairman of the Knowledge Forum Trauma and Infections for AO Spine. He's the editor-in-chief for Clinical Spine Surgery. So he's a pretty well-known surgeon for all of us. Today, he's going to talk about degen spondy, when to fuse and when not to fuse. So without further introduction, Greg, it's great to having you with us today. You're free to go from now on. Thank you for
Thanks,
having.
Alfredo. I really appreciate the opportunity to do this. This is a fun forum. So, like Alfredo mentioned, I'm going to talk about treatment of spinal stenosis and degenerative spondylolisthesis, and really when to fuse. I do think that I have conflicts, and when we think about this, I think the biggest conflict that we all have, or a lot of us have, are that I'm a spine surgeon and I do actually get paid more to perform a fusion than I do to perform an isolated decompression. Um, I do also work with companies that make instrumentation. I have royalties from Camber. I work with AO Spine. Have a neuromonitoring company that I own a portion of. So lots of conflicts, but nothing bigger than that I get paid more to do a fusion when we're talking about this topic. So I think one of the keys is kind of understanding where this all came from. And when you actually dig into the old literature, it's really quite shocking that these are the studies that really have permeated through and made our treatment, algorithm. So this one where Herkowitz looked at 25 patients in each group who had a fusion or a non-fusion for degenerative spondylolisthesis. There were not any patient-reported outcomes that we would talk about today. And realistically, what they found was that if you had a fusion, you had lower postoperative back pain and lower limb pain than if you did not have a fusion. But that's really the crux of the stats. This is something that if it got submitted to clinical spine surgery today with 25 patients, probably wouldn't get accepted. And yet this is the kind of uh, hallmark gold standard paper that we talk a lot about. They did further go into this. Fishgun published in 97, where they looked at 67 patients with degenerative spondylolisthesis. At 2 years, they found that instrumentation statistically improved the fusion rate, but it didn't necessarily improve the patient-reported outcomes. So, I'm not sure that this really suggests that every single patient needs a fusion. Um, I do think that it is kind of important to understand where this has all come from. And so this kind of took us to 2016. So in 2016, there were kind of dueling papers in the New England Journal of Medicine. And there are things you can like about both of them, and I'll go through them a little bit. So the first was a randomized controlled trial that was done out of Europe. I look at it, they ended up with the presence of spondylolisthesis. They had 67 patients in the fusion group, 68 patients in the decompression only group. So bigger than the Herkowitz study, but not extremely high. Baseline scores were all relatively similar. Things that you would expect to be the truth, right? Any person can tell you that the decompression alone group should get out of the hospital faster. Now, I mean, this is interesting to me, and it's one of the things that always raises a little bit of red flags for me about this study. I mean, they were doing a one-level decompression, and their patients were staying in the hospital for 4.1 days on average, right? Those patients in Philadelphia, unless they have major medical problems, are all outpatient surgery. Um, you know, a fusion patient stays in the hospital for maybe 2 nights, and they're there well over a week. Um, but, when you kinda get into the patient-reported outcomes and things like that, they had no difference in visits to the doctors. healthcare professionals, really nothing along those lines. And then when we get into breaking it down by really patient-reported outcomes, what you see is no difference at 2 years in ODI, EQ-5D, VAS scores. Really, the only thing that was a difference was that, it took longer to do a fusion, and the bleeding was more. That's, I mean, I think that is a common sense finding. Kind of published the same day or the same issue was Zogawala's, North American study, kind of looking at this exact same thing. Here they had a little bit of a small group pace, they're not depression pace, really no difference in their outcomes, um, or no difference in their preoperative studies. But then when we got into surgical complications, right, again, we would expect a little bit of an increased blood loss with fusion, a little bit of length of stay. Surgery took a little bit longer, but no difference in complication. But they actually did find a pretty statistically significant difference in improvement in SF-36 as well as ODI. And for the SF-36, this was true at 6 months, 2, 3 years, 3 years, and 3 years. And for better at 2 years and at longer follow-up, there appears to be some pretty significant benefit uh, with the fusion, and I think that this is the point that some of my partners will make is, but the question is, if you have somebody who has a spondylolisthesis, do they go on to progress? And so, maybe this study would suggest that long term, fusion is a little bit better. When you look at the sport trial, this basically showed the biggest issue with fusion is just that it costs a lot more, right? So we know in kind of today's healthcare environment, there's no doubt about it that a fusion is a more expensive surgery, right? You have implants that you don't have, you have increased length of stay of the hospital. So all of this is really true. I thought this was really interesting. Kind of a couple of years ago, there was another prospective randomized trial out of Norway, and this is one of the big things that they did differently in this study is that they actually allowed for some translation. So they allowed for up to 3 millimeters of flexion and extension. However, they still excluded any patient that had severe foraminal stenosis. And I think this is really key. Most patients who have some pretty significant translation are going to have foraminal stenosis. But in this case, if they had foraminal stenosis, they excluded them. They did find basically no difference in patient-reported outcomes, again, at 2 years in the ODI, whether you had a fusion or did not have a fusion. Reoperation was the same. ODI was the same. So again, no major difference in outcomes. And I thought this was a fascinating sub analysis of this, right? So they actually took these patients, and when they did the randomization, they asked the surgeons, "What would you recommend?" And they marked it down. And then you had the patients who they were randomized, so they went to something else. So there were 222 patients. A decompression alone was recommended for 112 patients, but 59 of them received a decompression. The other ones obviously received a fusion. For the 110 patients who a fusion was recommended, only 57 of them got a fusion. The primary outcome was a reduction of disability of ODI in at least 30%. And what they found was there was no in if you were treated the opposite way that they thought you should be treated. So at least for these surgeons, I'm obviously Alfredo, I think is probably better than this, but you know, even when we look at it and we say, hey, yeah, this person for sure is the person who's going to benefit from a fusion or not, we really aren't that good at identifying it. Now, I'm very critical. When you take a bunch of randomized trials and you just have a bunch of very small numbers, sometimes that doesn't always tell the whole story, right? We're all like trained in medicine. We need a prospective, blinded, randomized trial, but you just end up with a lot smaller numbers oftentimes. And I think what we end up seeing, I thought this was a great patient paper out of JNS Spine, is that actually probably when you have bigger numbers, there you can really kind of piece out that yes, a fusion, I do think in general is pretty helpful. So this was a patient of 600, or a study of 608 patients who had a grade 1 spondylolisthesis. 23% of them underwent a decompression only, and 77% had a fusion. And at 24 months, ODI was significantly greater in the fusion group compared to the decompression alone group. And fusion remained independently associated with improvements in ODIs in their multivariate regression analysis. They also did a propensity matching and found that a fusion was better. So I think I'm not going to say dishonest, but it's a little bit, only showing half the story if you kind of focus in on these couple of pretty small randomized trials and ignore kind of some pretty good pros or retrospective large studies. And that's basically what we see here when we look at this was a systematic review that only included randomized trials, and we've just talked about the fact that the randomized trials are pretty small. And so then they said, there is no difference in leg pain or back pain with a fusion or a not fusion. So I think one of the important things to talk about here is there's not a single study that suggests a decompression is better, right? Or there's a single there's not a single major study that talks about a decompression being better, right? So we all know that some patients need a fusion, some patients don't need a fusion, and I think unfortunately I'm not going to have a solid evidence-based answer here to give you, which is who needs a fusion and who doesn't need a fusion. I think the bigger point that I'm trying to make here is that when I was a resident, which was not that long ago, 15 years, it was, we had patient with a degenerative spondylolisthesis. Automatically, the answer was they need a decompression infusion. I'm not telling you that you shouldn't fuse patients, but I'm telling you that I think you need to think about it more pragmatically than just the way that it was on the American Academy of Orthopedic Surgery boards, which was degenerative spondylolisthesis equals fusion. Um, so this was a great paper, unfortunately out of Penn, where they looked at 679 patients who had, one of the risk factors for doing poorly with an isolated decompression is if you have bad alignment. And I mean, I think as surgeons, right, this makes sense to us. So if their pelvic incidence to lumbar lordosis mismatch was more than 10, the patients who had an isolated decompression had a pretty significantly worse patient-reported outcomes at 10 and 12 months than if they had a fusion. But if they were overall pretty well balanced, then there was no difference in outcomes. So it's not just a matter of do they have a spondylolisthesis or not. Are they balanced? We talked about the more recent study excluding foraminal stenosis, kind of the more classic studies excluding anybody who has a little bit of motion. This is one of the ones that we published recently, looking at 119 patients who all had a fusion. But I think one of the things that we found is that patients who have osteoporosis really, in general, have a much worse outcome with fusion than patients who don't have osteoporosis. Worse patient-reported outcomes, specifically their VAS back. So I think this is one of those ones where you got to look at it and you have to say, all right, so we know if a product is something which is more towards saying, hey, you know what, we should try not fusion because it's higher, loose screw rate is higher, back pain is higher. We need to really think about whether or not this patient needs a fusion or not. There was a study recently, there was a survey of LSRS and SMIS, which is, for those of you, that's the Society of Minimally Invasive Spine Surgeons. There were 381 surveys on degenerative spondylolisthesis, and they found that only about 20% of people would recommend fusing them all the time. 40% of people, though, fuse more than 75% of the time. And the thing that really fusion or any type of interventions, any type of spondylolisthesis over a grade 1, and any type of lateral listhesis. The clinical parameters were really low back pain, activity level, and the neurogenic claudication actually was something that led towards a decompression only. The low back pain is one that is interesting that I think we can talk about because, I personally think that it is really challenging to predict how people are going to do from a back pain standpoint after surgery. So I actually will tell all of my patients, whether I'm doing I tell them whether I'm doing a fusion or only a decompression, spine surgery is very good at treating neurologic pain in the butt and down the legs, and very bad at treating back pain. So the back pain doesn't really come into my algorithm because instead I tell everybody, I don't know if your back pain is going to get better. Don't have spine surgery for your back pain. You have spine surgery for your nerve pain. And I'm sure there are patients who I probably operate on less than I could because of that kind of discussion. But I just, I think predict if somebody is going to do well from a back pain standpoint. So using that as a reason to put in screws, I think is a bad idea. They actually copied one of our studies that we had done about 10 years ago now. We surveyed LSRS members and AO spine members. And the interesting thing, the reason I bring it in is, at least at the academic level, what you see is that, in 2015, almost 50% of the surgeons were saying they would fuse everybody, where that's down now to about 20% of surgeons today. So there clearly is a little bit of an academic movement to say, hey, maybe not everybody with a degenerative spondylolisthesis needs a fusion. A little bit of an awkward graph from the study because non-flexion and extension films was kind of the biggest predictor of needing a fusion. Again, moderate to severe back pain, and then the spondylolisthesis grades. So I don't think there's been a lot of change in what people are thinking when we look at why people would fuse them versus why they would not fuse them. But I thought this was really fascinating, despite the fact that, I just showed you, two different surveys from, 8 years apart, suggesting that we're having a major, resurgence in doing isolated decompressions. At least in America, when you actually look at the data, that is just not the case at all. So this was a study looking at, a national insurance database with patients with a degenerative spondylolisthesis from 2010 to 2022. 162,000 patients were identified. 78,000 underwent a fusion, and 84,000 underwent a single level lumbar decompression. A little bit of what you would expect. Decompression only is more older, more sicker patients, and more likely to be done by neurosurgeons. But when you look at the overall trend, we see exactly the opposite. Surgeons are so 2010, a decompression only was about 70% of the cases, where in 2021 that number dropped all the way down to 45%. So pretty remarkable decrease in the number of patients who are actually having an isolated decompression, in spite of the fact that there's really a growing body of literature and really more people, at least in the academic world, suggesting that this is really something that should at least be considered. So not to get into too much of it, but I do think that it's important to understand that there are lots of different kind of fusion options. It's not really the goal of this talk, but the reason I bring these up is just because I think it's worth saying, like, listen, there's not one way to do a fusion or another way to do a fusion, right? MIS versus open TLIFs. This was a good systematic review that was published pretty recently, looking at 1,300 patients. And what they found was there were no significant difference in PROMs at 2 years. Both treatments resulted in a high rate of spinal fusion, low rate of reoperation, low rate of adjacent segment disease, obviously significantly increased rate of bleeding and length of stay with an open case, right? I mean, I'm not the guy who's going to tell you, hey, listen, you've got to do an MIS TLIF versus you've got to do an open. I think the point is, at 2 years, if you take care of people's neurologic symptoms and do a good fusion, your results are pretty similar. There are a lot of people now, myself, laterals. And when we look at this, right, the evidence behind lateral fusions working well is really strong as well. This was a good study where they looked at 107 levels, 3 different patients who had spondylolisthesis and stenosis. They had a minimally invasive lateral and percutaneous instrumentation, and they actually got MRIs on everybody. Compression does work. It leads to a pretty significant improvement in the central canal area. And in their study, only 2 patients, or 6%, required a direct decompression. So I think this just goes to show, right, you have somebody with a spondy, you have somebody who has stenosis and neurologic symptoms. There are lots of different ways that you can treat these, whether it's a decompression infusion. I think these are all reasonable options. Myself personally, I actually do like to do a lateral. I think that it has a little bit of a better, not a little bit, a lot of a better fusion rate. I think it restores the lordosis a little bit better in my hands, and the patients are able to get out of the hospital a lot faster than kind of a traditional open surgery. So this was a case of a lady that I did, who was about 62, had pretty severe pain in the button down her legs, pretty severe stenosis at L4, L5. This is kind of, in my mind, the case that we're all talking about, right? It's, here's a lady, she's got stenosis, she's got a spondylolisthesis, she doesn't have a lot of motion on her flexion and extension films. Could we have just done a decompression only? Probably. Would it have led to, I think, good results, at least in the short term? Yes. I mean, I think the literature clearly states that. Zoe's paper would make you think, maybe she'll have a better outcome if she long term has a fusion. And so that's what I did for her. So to me, and this is just kind of collecting everything that I talk about, is, for a single level degenerative spondylolisthesis, what do I think about? For the first thing I think about is flexion and extension films, right? I recognize that there's a study that says that you can have motion on flexion and extension films, and that doesn't matter. But that's one that I always question. Like, there's scientific evidence and kind of common sense, right? So to me, the common sense answer, you have a pretty significant mobility on flexion and extension films. It would just be hard for me to suggest that you are going to destabilize the spine no matter how you do it, even if it's a little bit by that, with more than a millimeter or two of motion on flexion and extension films, that you're not just asking for trouble down the road. I do think paramelosis, I think, is a big question, but I don't think it's enough to say foraminal stenosis, right? Because we all know that there are a lot of people who have a really collapsed 4-5 disc space. They've got pretty significant foraminal stenosis, but really, why are they in your office, right? They're in your office because they have, pain when they walk to get the mailbox. They've got claudicatory symptoms. They have no radicular symptoms. Um, and so it's not that they can't have severe foraminal stenosis, but if they have significant radicular symptoms and foraminal stenosis, that's a major red flag for me. Other things that I look at a lot are bone quality. And when I think, and to me, bone quality is not just a question about um, fusion versus non-fusion. I also worry a lot about bone quality when we talk about implants that we're selecting for. Um, should we do an inner body? Should we not do an inner body? Um, demand level. What is this person really asking? What do they want? Do they want to be able to shuffle back and forth from their kitchen to their bathroom, to their bedroom? In which case, if isolated decompression is probably a great option. And I'm say risk of complication with surgery and obesity, I kind of put in the same group, right? The sport trial says that you have about an 8 times the rate of infection if your BMI is 40 compared to BMI of under 30. So to me, that's a real red flag. And I will actually have the conversation with patients and say, listen, your BMI is 43. You've got severe stenosis. I am not going to be able to get rid of your back pain no matter what because your BMI is 43. But I can unpinch your nerves, but I think you're at a real high risk of failing. But I just don't think that it's a great option to put in hardware in somebody who I think has a high risk of infection. So BMI is over. Oftentimes, we'll recommend a decompression only. The take-home point for me on this talk is really for a single level spondylolisthesis, realistically, a dogmatic approach is really the right answer. Um, you know, at least when I was a resident, the Academy of Orthopedic Surgery got this wrong. It's not that everybody who has a degenerative spondylolisthesis needs a fusion. I do think a whole lot of patients who have a degenerative spondylolisthesis would benefit more from a fusion. But you need to be a doctor, not a mechanic. Look at all of this stuff. Talk to your patients, and weigh the risks and benefits, and try to identify what's the best treatment that you can give for this patient in as safe as a way. All right, that is what I've got. I'm happy to talk about any questions if anybody has anything.
Awesome, Greg. Outstanding presentation. I get a lot of questions. I mean, there's a lot of gaps in the literature that I
That
would
is
like to.
100% true.
So, first, why do you think it's a tendency to do more decompressions nowadays than fusions? We see that in every single congress that it's a lot of pushing or tendency to go to endoscopic decompressions, and we see less and less T10 to pelvis. It's because
Right.
of these studies you show, the New England Journal, the Norway studies. It's because of the bad results we had with fusions, or is it because endoscopy is a fashion, or I don't know. What do you think?
Well, I mean, so a lot to unpack in that question. So first off, I'm being recorded. So the T10 to the pelvis fusion, um, I mean, I really struggle with it. I used to do it a lot. Um, I think that when you look at predicting who is going to do really well and have a low complication rate with the T10 to the pelvis fusion, right? Most of the people who come into my office who, like, if you did all of the appropriate measurements and things like that, are these like 75-year-old Caucasian, very osteoporotic women. Um, and it's just, I always go back to, there was an old paper that Dan Scuba wrote, where he talks about patients over the age of 75, who have deformity surgery. It's like 25% of them are having a revision surgery within 2 years. I mean, like, the magnitude of surgery that you have to do for a lot of these people when you talk about, adult deformity surgeries, and the benefit of the outcomes. I think people are a little bit concerned. I think like 10 years ago, people were doing a whole lot more of it. And now I think that pendulum is kind of swinging back. So, I mean, I think there's the deformity question. And then there's the question that you raised about, I think that the interesting thing is at meetings, there's a lot of talk about it, right? I mean, that's what you're saying. Endoscopy, tubular this, only decompression. But when we look at the actual answer for what people are doing in the community, they are doing one level fusions more so now than they were 10 years ago. That was the interesting ball study. So I think that some of this is, I think there's being a bigger push academically to say, hey, maybe we went overboard. And I think that's probably due to some of the issues that we've seen with complications, flat back deformities, things like that.
Awesome. Andrew Grossback is with us. If you want to jump in.
Yeah, absolutely. No, great talk. I think this is, I mean, eternally debated, right? I think the thing we miss in all these studies is, a lot of it's the conversation with the patient. And so I have a lot of these low grade spondies that I don't know the right answer. It might be a decompression, it might be a fusion. And sometimes it's talking over with the patient and saying, listen, we can give the decompression a shot. And if it doesn't work, can always fuse it. Can't unfuse it once you fuse it. And there's some people that say, yeah, I want to try and avoid it, a fusion. And a lot of the studies, the ones that fail are the ones that go back to, a repeat surgery. But I don't necessarily think it's a failure if you offer somebody like a minimally invasive decompression, they don't get enough better, and then down the road they get a fusion. Obviously, you don't want to take everybody for two surgeries, but I think there's some in that middle ground, and so there's probably plenty of people that yeah, you avoid the fusion and they get by with the decompression. There's some that don't get better with the decompression, then you confuse them, and so I think a lot of those ones that are in the gray area, you have a conversation with the patient, you kind of lay out the options, the pros and cons of both, and some will tell you like, yeah, I want to give the decompression a shot, and some say, I just want to do this once. I just want to get it taken care of. And that leans you more towards the fusion. But those are hard things that you can't really, you know, put in a study and say, oh, we'll let the patient pick what they wanted.
Well, but I mean, I think you make a really great point. I mean, I talk to our fellows about this that, yeah, of course, spine surgery is technically challenging. That's fine. But the more technically challenging part is discussing it and having it with the discussion that you have with the patient, right? Because for sure, like there are some people who if they needed to have a second surgery, 6 or 9 months down the road, they look at you like you're a failure. And there are a whole bunch of other people who are like, "No, listen, we had this conversation. You said that you thought that, we were gonna try to do the smallest thing first." I tell patients, I'm like, "Listen, we're not burning any bridges." And particularly, if you're comfortable doing kind of like a minimally invasive lateral and perc screws, if you've already done the central decompression, I mean, that's a home run case, somebody who's been centrally decompressed, and then do a minimally invasive lateral and posterior fusion. So I think that kind of conversation, you're right, you can't get that in the literature.
100%.
Absolutely. I think the low-grade spondylosis is like a spectrum of pathologies. Uh, Goes in the same bag. You put in the different facet joint angulations in the same bag. You
Right.
put in fat patients with low BMI in the same bag. You put in high disc patients with low collapse disc high patients, and you compare techniques for different things. So if
Right.
you have pretty good number of patients, like for pretty similar patients in the same cluster, and you compare two techniques, that's much more reliable than these big randomized studies with 40 patients on one side and 40 in the other.
Right.
They're completely mixed. It's like we're comparing techniques in different patients. So what are the factors you consider? You mentioned obesity, you mentioned bone density, but what do you see a part of clinical findings? If you have claudication, we know it's central stenosis, but have claudication plus radiculopathy, you're more tend to go for a fusion and a huge
Yeah,
decompression, or
absolutely. So and that's what I was trying to get at with the foraminal stenosis. I don't think saying somebody has severe foraminal stenosis, particularly in like old patients, right? Almost all old
Mhm.
patients have multi-level severe foraminal stenosis. So just the radiographic finding of it to me is not enough to say, hey, listen, you're going to have a fusion. But if they have a radicular component, they're getting a fusion in my hands because I want to make sure that we got the foramen decompressed. And so I think the radiculopathy is much more important to me than say the back pain aspect. Because I feel very confident that if I get the nerves completely unpinched, the radiculopathy is going to go away. I feel much less confident, particularly in patients who have, multi-level degenerative changes in their back, that if I get the one level to fuse, their back pain is going to go away. So from a
Mhm.
patient standpoint, the things I think about are realistically The radiculopathy is probably the biggest one. The discussion with the patient, the neurogenic claudication kind of pushing it the other direction. Um, and then the other things that I do think about are really, avoiding complications, right? I mean, I think I talked a lot about laterals, but I think a lateral in somebody who is wildly osteoporotic is a terrible idea, right? I think almost any kind of interbody fusion in those patients, like you put it in, it looks perfect, and they come into your office and it's, cages in the body. So I try to avoid that. So those are probably the big one clinically ones that I think about.
So you mentioned that back pain was one of the factors surgeons used to decide for fusion, right?
Yeah.
I think we all agree that if you have isolated back pain, it's not a good idea to do a fusion. The rates of bad outcomes are pretty high. So why we use back pain as a critical factor to decide in a spondy to go for fusion when we don't use fusion for back pain? Why are we so biased to do that?
I think it's because we want to tell patients that, listen, we did everything we possibly could for you. I think that's why we do it. In my hands, that's, like maybe if you were somebody who had, pristine discs at 4 levels and you have a lumbar degenerative spondylolisthesis with severe stenosis at 4 or 5, but I mean, that is the unicorn of a patient, man. I mean, usually it's the person who comes in and they have, degenerative changes up and down their spine. They've got severe stenosis at 4 or 5, and a spondy at 4 or 5. That person, I have no idea if their back pain is going to get better. And um, I think it's a more challenging discussion to have with the patient, but to look at the patient and to say, honestly, I do not know if your back pain is going to get better with or without surgery. And, I mean, what I tell my patients is I say, if you had surgery and your leg pain got better and your back pain was the same after surgery, that you would be frustrated that you had surgery, then I tell them not to have it. I say only have it if you can look yourself in the mirror and say, if I went through this and my pain in my butt and down my legs was better, regardless of what happens to my back, I'd be happy. Then I think it's a home run, have surgery.
Yeah, absolutely. So the Andrew, you want to do a question?
Yeah, I think it's I mean the back pain point is interesting because I mean my go-to line is like, I always tell patients, operate for nerve pain. If your back pain's a 9 and that can get you to a 5, most people are pretty happy, 4 or 5. Um, the hard part, so I think fusion surgery does work for back pain, some back pain. The hard part is knowing which back pain is going to work for. I have some, you have patients
Totally
come in,
agree. I totally agree. There are
they're
some people who are dramatically better.
yeah,
I just
it's
don't know
like
which ones are going to be.
I don't know either. Some come in, their facets look absolutely terrible. They're all, like flame T2 hyperintensity in them, and I'm like, I'm sure that hurts, and I'm sure if I fuse it, it'll get better. But the thing I don't know is, do the other facets hurt? Is it musculoskeletal, muscular thing? Is it because they're obese? Like a whole bunch of other things. So some patients definitely get better. Um, the things besides just talking to the patient and seeing what they're expecting, and are they going to be the one that's pissed off if they have to come back in 6 months to a year for a fusion after decompression versus not. I look for instability. What is instability? It's like I can't define it. Sometimes I know it when I see it. Sometimes I'm on the fence. um a grade 1 spondy, you know with a little bit of a slip angle, I think is different than one that's has great lordosis at that level.
Right.
We don't take that into consideration in a lot of these studies. We just talk about grade 1. I don't like flex X films. I get them. It's like it's an effort dependent study, right? Some people like barely bend. Some people flex at their hips and they don't bend their back at all. Other patients are like, put all that effort into it. I prefer
And
like
how do
up
you, oh, I was going to ask you, what do you use then?
supine upright. So I,
Okay.
I take a supine from either my MRI or my CT and
Okay.
my upright standing film. And I think that gives more more reliable. If there's a difference between them when they lay down and when they stand up, I think that gives me a better predictor if there's actually instability. I try to, do, clinically, is it better when you lay down? Is it worse when you stand up? Things like that. So I try to take all those factors into account. I think the radiculopathy point is excellent. I think if somebody comes in, they're just claudicating, it's like back, yeah, it's sore, it's not terrible, just claudicating. Maybe there's a little bit of motion. I'm probably going to try a Lamy on that patient. I think if they come in and they have a searing radiculopathy, it's probably going to lead me more towards fusion. Sometimes you can, if you got a 4 or 5, grade 1 spondy and they have a radiculopathy, it's like, this is clearly the traversing route versus the exiting route.
Good point.
That might, I tell people I'm really good at the central canal with a Lamy. I'm okay at the lateral recess, medial facets. I'm terrible at the foramen. I'm sure there's people that do way better foraminotomies than me. So I'm like, if it's foraminal and it's exiting route, I'm sure of it. It's a fusion. If it's traversing route and that there's something that correlates, that a case I did yesterday. It was like a mid 80s scoliosis, just unilateral, like L4 radic, and had this facet with this lateral recess stenosis that, like, if I just drill like the medial third of this facet, is like that nerve was the one on the MRI scan. So there's sometimes like that, then I'll get by with a like a targeted decompression. But sometimes that's hard. They come in, they're like, my leg hurts. And it's like, where exactly? Does it go to the big toe? Does it go to the ankle? They're like, I don't know, just down my leg.
The whole leg.
Yeah, the whole leg. And so sometimes you can't figure it out clinically. Sometimes they get an EMG and it's like, L2 to S1 radiculopathy. And it's like, that's not helpful. Sometimes I swear the people doing the EMGs think the nerve roots are numbered like the disc spaces. Like there's a L5S1 radiculopathy. It's like, that's a disc, not a nerve. Like which nerve is it?
I'm going to say that that's half of the EMGs that I get.
Yeah.
That's not helpful. It's not a 5/1.
Yeah.
It's not a thing.
So sometimes you can figure it out and be like, all right, great, I got it. Sometimes you can't. Sometimes when you can't, you have that conversation, say, all right, we're going to do everything we can, or we're going to do the minimal stuff, and then can always do more later. And yeah.
That's a great debate. I mean, there's also a technical bias. I don't do decompressions exactly the same like Greg or like you, Andrew. Neither my fusions are yours. I mean, we're comparing techniques from different guys. So
right.
We see terrible fusions, kyphotic fusions, only posterolateral fusions in young patients. They're gonna fail in the short term. So how we can address that these techniques done in these studies are probably well done, well decompressed, and the patient didn't fail for the bad decompression or incomplete decompression or over decompression, or the fusion is kyphotic, or the patients were not selected. I mean, we're using these studies to guide our treatments, and they're pretty. I mean, there is the better evidence. It is. It's good. I don't think so.
I think what the evidence tells me is, again, I'm going to say be a doctor, right? Because I think that there's clearly patients who will do well with the decompression only and patients who will need a fusion. How you kind of find that out, I think everybody's got to kind of find their own way with that as a spine surgeon.
Yeah, we try to offer the standard of care for patients, but
right.
When my patient goes to 4 or 5 different surgeons, they offer different standards of care, and they're not bad. I mean, they offer fusion, done. He probably offer an ALIF plus laterals, and or we offer all different things. They're all standard, so we steer a pretty artistic way treating these problems and not a scientific way. That's what I see for Degen Spawning. We're still talking about the same fusion versus no fusion after 30 40 years of conversation. So in your practice, when you do 4 or 5 Degen Spawning, what is the percentage of patients you fuse, and what is the ones you decompress?
I bet I'm 80-20, 70-30 to fusion.
Got it.
Same.
Andrew, same.
Same. Yeah.
So we are fusion guys. But if we present this at SMEs, there are two groups. It's the endo group and the endoscopic group. There's all decompression for everything. Ischemic spondy decompression. And
now you're just talking blasphemy, right?
Yeah,
Right?
really.
Like,
And the prone lateral guys, no, all 4 or 5 spondy is prone lateral and then perks. So it's a huge bias, and what I
I
try
did
to
2 prone
highlight is
laterals today, so I mean maybe I'm biased, but
so when I'm trying to focus it, highlight it's like we're pretty biased today with the treatment of this pathology, and we need to be doctors and not mechanics, as you mentioned. Take much more factors that the literature describe for this pathology. I think that's a great message. Any other question, Andrew, or comments?
I don't think so. It was a great talk.
thanks for
Thanks,
having me,
Greg.
Alfredo. This was fantastic. I really
Was
appreciate it, guys.
was a pleasure to have you. I will like to have you again soon. It would be great to talk about the trauma, all
Sure.
your focus.
Yeah,
And
anytime.
we appreciate all the audience to be here, all the questions remain. So we'll see you next week for the weekly session of Global Spine, Virtual Global Spine. Thank you all. Good night.
All right.
Good day.
Have a nice one, guys.
See ya.
Bye.